Afternoon. My name is Karen Marshawn Singleton. I am an undergraduate student at Western Governors University. My topic for this evening is end-of-life care and underutilized resources in American healthcare. I'd like to begin with the statement that end-of-life care should focus on palliative care, not necessarily curative care, in order to conserve healthcare spending. As an introduction, I'd like to state that healthcare in America is a very hot and sensitive topic. Every person utilizes healthcare at some point in his or her life between birth and death. Healthcare in America is a multi-billion-dollar industry. Financial resources for healthcare are being stressed to the limit. When efforts to restore a patient to optimal health have failed, end-of-life care should begin, but often does not. Hospice care is an option available to patients with terminal conditions. Many people think that medical care provided immediately, the moments before a patient expires, is what is considered end-of-life care. However, the hospice philosophy is that end-of-life care begins with a diagnosis that is life-limiting and can potentially end the patient's life within 6 months or less. With this being the case, the question arises, why hospice care is not utilized more? If it's such a great benefit, one would think it would be utilized. Many healthcare experts have identified that inadequate management of pain in the terminally ill is one of the biggest problems. Fear of legislation for improper medication, authorization, and distribution causes fear for many providers and makes them hesitant to prescribe adequate pain medication. This is documented in works of Morris that goes back as far as 2001. The diagnoses that make a patient eligible to participate in hospice care have changed, and many providers are not current with hospice diagnoses. Many years ago, only cancer was the diagnosis for which a person was placed on hospice. The diagnoses that are appropriate now include diseases such as Alzheimer's, dementia, and debility. As recently, and although it does not seem recent considering we're in 2011, but as recently as 1992, 75% of patients who were on hospice had cancer diagnoses. Let's jump to 2005. Less than 50% of all patients in hospice care had hospice diagnoses. I have a visual aid that gives some data from 2005, which shows that diseases such as kidney disease, lung disease, debility, heart disease, and other diagnoses, which compose about 14 to 15% of those diagnoses, made up the diseases that were eligible for hospice care. Cancer was less than 50%. Actually, according to this statistic, it was 45.9%. The government recognized that there were more life-limiting diagnoses that would make a patient appropriate for hospice care and has, over the years, increased the number of diagnoses. In 1990, the federal government enacted what is known as the Federal Patient Self-Determination Act, which addressed the rights of patients to choose how they wanted to be treated by healthcare providers. The law was intended to educate the entire population of the legal rights and opportunities that are available to make informed healthcare decisions and to have those decisions be respected. In order for a physician who receives any payment from Medicaid or Medicare or any hospital, nursing home, facility of any sort that receives such payments, in order for them to be paid, they have to comply with this regulation. It is a federal mandate. Any provider who refuses to follow these directives because his or her conscience says that they must do everything to save a person's life, they have to register their objections with the state in which they practice. That's how serious this is. Advanced directives are required as community education for all federally funded facilities and managed care plans like Social Security and disability. The Department of Health and Human Services is required to make assistance available for patients in each state and to oversee the compliance. Effectiveness of this legislation is debatable, but it does open up a means for individuals to make their wishes known. In conclusion, the American healthcare system is in peril. Efficient use of healthcare dollars is essential in order to be able to continue to provide care. Options for end-of-life care are few, and the choices are very difficult to make. But those options become even more limited when they are not presented equally. Utilization of advanced directive aids an individual in making their wishes for the health care known to family and provider alike. Despite the recent advent of living wills and medical power of attorneys, many patients still live out their final days alone or in a hospital connected to tubes and wires that they really didn't want. Hospice care for patients at the end of life is a resource that is largely untapped and widely misunderstood. Open discussion for hospice care by physicians with patients and their families is a valuable tool that deserves presentation as an alternative to hospital care for dying patients.